Hello, my name is Dr. Diwan S. Raja. Today I will discuss about ventricular septal defect. The ventricular septal defect refers to the abnormal communication through the interventricular septum. So, here is the interventricular septum between the left ventricle and right ventricle. The blood in the left ventricle should be separated from the blood of the right ventricle by means of interventricular septum. Interventricular septum has upper part, it is membranous, lower part is muscular. So if you go to the circulation of the blood through the heart, this is the inferior vena cava, this is superior vena cava. Blood is returning to the right atrium, from right atrium blood is going to the right ventricle through the tricuspid valve or right atrioventricular opening. From the right ventricle, blood goes out through the pulmonary trunk, pulmonary artery, go to the lungs, left lung, right lung. It is oxygenated, returned back by means of pulmonary vein. We have four pulmonary veins. So after it reaches the left atrium, from left atrium, blood goes by means of mitral valve at the left atrioventricular opening to the left ventricle. From left ventricle, blood is pumped out through the ascending aorta, pulmonary, then ascending aorta, then the arch of the aorta, and the descending thoracic aorta. So this is normal heart circulation in case of ventricular septal defect. So there is defect maybe in the membranous part, maybe in the muscular part, maybe one defect, maybe multiple defect, maybe small defect, maybe large defect. What will happen? Pressure on the left side is always higher than that of the right side. So if there is a gap here, blood from the left ventricle will go to the right ventricle through the gap. And it will go to the lung will be congested. Eventually, there will be high pressure development in the pulmonary vasculature. So there will be reversal of blood flow from the right side to the left side. We call it Eisenmenger syndrome. This happened after many years of ventricular septal defect and left to right shunt. Then eventually formation there will be pulmonary hypertension and Eisenmenger syndrome. Okay, so if we go here, around 30% of all congenital heart defect is the ventricular septal defect. It is the most common congenital heart defect. If small spontaneous closure may occur by adulthood, prevalence is 1.17 per 1000 live birth. Prevalence means the number of existing cases. May be associated with other congenital birth defect like atrial septal defect, patent ductus arteriosus, coarctation of the aorta, aorta may be narrowed, okay, and phellostatology here is an example, this is an image of phellostatology. Here we have also ventricular septal defect, pulmonary stenosis, dextroposition and overriding of the aorta. So aorta get blood from both the right side and the left side, and certainly right ventricular hypertrophy. So this tetralogy or patent ductus arteriosus or atrial septal defect or other heart defects may be associated with ventricular septal defect. It may be a complication of myocardial infarction in an adult. In an adult, if the adult person has myocardial infarction, there will be necrosis of the muscle here, and following necrosis, there will be shunt from the high pressure left side to the right side. So it is not always congenital, it may be acquired after a myocardial infarction or MI. Okay, so what is the clinical presentation? Clinical presentation depend on the size of the defect and the ratio of pulmonary vascular resistance. In infants, it may be asymptomatic. Infant means the neonates. It may be asymptomatic. Why? Because the infant has more vascular resistance in the pulmonary circulation. That's why there is no shunting and there is no murmur to the newborn children, although they may have some type of ventricular septal defect. Left to right shunt in the absence of pulmonary stenosis and pulmonary hypertension. Left-sided heart failure, dyspnea on exertion, tired very easily. The small children, when they play with their peers, they may take rest. They cannot cope with other kids, other children. There will be orthopnea, machine-like hollow systolic murmur throughout the systole from S1 to S2. S3, heart sound and rains. Eventually, reversal of shunt and Eisenmenger syndrome develop. Okay, so there will be high pressure by this time will develop in the pulmonary circulation, and then there will be high pressure on the right side. Blood from the right side will go to the left side. So that happened after many years of left to right shunt. Now there will be right to left shunt. That is the Eisenmenger syndrome. Okay, how can you diagnose? If we do the complete blood count, we may see polycythemia due to hypoxemia. Arterial blood gas may demonstrate hypoxemia, and ECG will show the pathology. It may be right ventricular hypertrophy, so there will be right axis deviation, maybe other as a whole heart may be enlarged. It may manifest in that way. Chest X-ray, cardiomegaly, heart will be enlarged. Echocardiography is the imaging modality of choice. Okay. Treatment depend on the type, size, and shunt, and treatment should be determined by the cardiologist or cardiothoracic surgeon, especially the pediatrics cardiologist and pediatric cardiothoracic surgeon. It can be observed in the young children for spontaneous closure. We discussed small closure may be closed around 50 to 70% cases. Even the large gap may be closed around 10% cases. Then the definitive treatment is surgical closure for the large defect. Okay, and that's all about the ventricular septal defect. If you have any question, please feel free to ask me. And please support my channel. Please subscribe me. Have a nice day. Bye now.